kids will maintain.
Hello, everyone. Welcome back from lunch. I hope your bellies are full, and I hope you had a great time interacting with all of the representatives out there. We are at the second half of our presentation, and I would like to turn the mic over to Deb, and she is with TMC Health Foundation, and she just wants to spend a few moments with you guys. So take it over.
Hello, everyone. Welcome to our Tucson Medical Center campus, and thank you all for the work that you do. Firstly, I'm in awe and grateful for your service to the community and the professional job that you all do every day. So I am Deb Dale, and I'm the relatively new leader of the TMC Health Foundation. And we are the nonprofit fundraising arm of TMC Health. And that now includes not just Tucson Medical Center, but 3 other hospitals in TMC Rincon, Benson, and Wilcox. And also about 150 physicians now have brought their practices into TMC Health under the TMC One umbrella. And then we just merged with Arizona Oncology, so we have 6 cancer center sites all over the community. So we are full bore, just going for it. And I'm excited about that because we are the last remaining locally governed hospital healthcare system left in Southern Arizona. So to me, I'm a native Tucsonan, so to me that is very important. So I am happy to go out every day and talk to donors in our community and explain why what we do is so important. And we raise money from major donors. We raise money from people like me who are not major donors but still want to contribute. We raise money from our boards of directors, from our employees, from foundations. So really anybody that wants to support locally governed healthcare in this area, we are in communications with them and always gratefully accepting their donations. Another big piece of what the foundation does, thank you. I tried. Another big piece of what the foundation does is, you probably know, but if you don't, TMC for Children is one of only 2 Children's Miracle Network hospitals in Arizona. So it's TMC for Children and it's Phoenix Children's Hospital. We're better. So Children's Miracle Network is a national partnership of major corporate sponsors. So Costco and Walmart and Ace Hardware and Dairy Queen and Love's and Panda Express, and I could go on and on. So they build these national partnerships. So if you do go into a Love's right now, they'll ask if you want to buy a $5 balloon or a $1 balloon to donate to Children's Miracle Network. The money all comes to TMC for Children. So we keep all that money locally, but we have access to all of their customers throughout the year. So for example, with Panda Express, I was unaware of the depth of Panda Express. Still a family-owned company. They provided $600,000 to TMC for Children to do our pediatric therapies playground across the way in one of our other buildings on Grant Road. So just amazing, the amount that a whole lot of people coming together with not that much money at a time can impact is huge. So CMN is how we get a lot of the money that we use to support the pediatric endocrinology programs here at TMC Health, including this. I think we're a sponsor of this, so glad to have you here. Because we think it's important, and those Children's Miracle Network dollars are pretty unrestricted. They go to pediatrics, that's the only rule, but we can decide as a team collectively where we want to invest those dollars. And there's nobody else worth more investment than you all. So thank you for keeping our kids safe, and thanks for everything you do, and we're just grateful, and it'll make me cry, but we're proud to have you as partners. Thanks.
Welcome everybody. Did you enjoy lunch? Thumbs up? Alright, great. So I'm Jackie. I'm back to talk pump troubleshooting with Callie, one of our other dietitians and diabetes educators. Hopefully you guys had some time to play around with all the pumps. I'm gonna ask if you could raise your hand if you have students that are using a pump currently that you are dealing with on a daily basis. Almost everybody, I'm sure. But maybe there's a new pump that you were able to also see, or just getting some more information directly from the source is always helpful. Now we're going to talk through troubleshooting, but the disclaimer is this is very generalized information. We're not going to be talking about the very, very specific maybe changes one student to another might have in their orders. We're really going to just talk about functionality of pump, the functionality of pumps in the automated mode now working in conjunction with the sensors. We're going to talk about all the sensors. So again, just kind of introducing to all the products that are available, that you are going to be seeing, pump and sensor, and how we troubleshoot some of the tech issues that we may have. Because as you've probably already learned, the tech piece is amazing, but it's not foolproof, it's not perfect, and we definitely have some like malfunctions and issues that come around. And so we're just going to be kind of talking through what to do in these more generalized situations. All right, so our pumps. Were there any pumps out there that you guys hadn't seen? The eyelet. All right, we're going to be talking a lot about the eyelet. So the Omnipod, that tubeless pump, Tandem makes the two different pumps, the X2 and the smaller Mobi. The Medtronic pump, one of the kind of old school devices out there around for a really long time, and then the absolute newest on the market, the eyelet. So what are pumps? What do pumps do? Well, pumps are little electronic devices that kind of mimic what a pancreas is doing. So pumps use fast-acting insulin, and they continuously deliver small amounts to cover that background or basal insulin. If a child is not using a pump, they're using a long-acting insulin, that one injection a day of long-acting insulin. This is a much more fine-tuned way of them receiving insulin. It's a rate that, again, is more closely simulating that of a pancreas. Pumps, though, are not pancreases. So there's still a lot of stuff we have to do to assist the pump so that the kids can get really the max benefits from them. Through the pumps, we can also do dosing for food and sometimes also for correction. So with the pumps that we have up here, the Omnipod, the Tandem pumps, and the Medtronic pump, not only are they going to be receiving that kind of all the time background basal insulin, but we can enter carbs or sensor or glucose data to deliver additional insulin based on those needs, whether they're eating or their numbers are higher or both. All right, but the eyelet is a little bit different. So I know we've kind of been like introducing a bit about this pump throughout the presentations, but we're just gonna get more specific right now. So some of the things that make this pump unique and that you're going to see are different in terms of how you're using them. One, there are no settings. I know that sounds like super bizarre if you're used to the other pumps. There is no correction factor. There is no insulin to carb ratio. There is no adjusting on our end clinically. The doctors can't adjust for these with this pump. So that is just not something that we do with this pump. This pump has an algorithm that essentially is learning the child's body over time, and that algorithm is driven by the target glucose. So this is a pump that works in conjunction with a continuous glucose monitor, and because there are no settings, there really is no manual mode option. With this pump, if the child, I'm actually getting ahead of myself a little bit, I've got a slide on what I'm about to say, so I'll back up just a touch. So again, there's an algorithm for correction, which means we can't enter a blood glucose for correction. It is its own separate algorithm that we just allow the pump to manage, as well as the basal needs. And there is no counting carbs. Okay, that's not to say that we don't enter something. Okay, so an individual who's using this pump is going to be estimating volume of total carbs, not exact grams of carbs. And there is a bit of a distinction that can kind of seem a little bit gray. So a lot of this is going to be parent driven. That's really important to understand. It is not your role to know what a child's usual lunch looks like at home. Okay, that is for the parent to assist you with. Some individuals you might see on this pump would be those who are just totally burnt out with carb counting, that are really struggling with entering carbs, individuals who maybe just aren't so comfortable carb counting and just really are looking for another way of managing their carb dosing. And then also, this is a bit off topic, but we do see that there's increased risk for disordered eating and eating disorders with children living with diabetes, and sometimes exact carb counting isn't really the healthiest way to go about managing their diabetes, so those might be some other kiddos that you see. All right, this is a really lovely slide. This is something that you are also going to see if you have a child that uses the iLet, because it is in their school orders or their DMMP. So we still acknowledge that carbohydrates are going to be consumed, but we don't acknowledge them with grams of carbs. We acknowledge them with the volume of the carbs being either usual, so the same as their typical meal. If this is lunch, it would be their usual lunch carb volume, more than or less than. If they're consuming typically fewer than 10 grams of carbs, it wouldn't be announced at all. It's important with this pump that the meal announcements are done between 15 minutes before the meal and no more than 30 minutes after the meal. So ideally 15 minutes up to the minute before the meal is consumed, because it does have an aggressive algorithm and we want to prevent the possibility of lows. So again, no carb counting, we are estimating the volume.
On the example outside, it didn't have like snacks, it just had breakfast, lunch, dinner.
I'm so happy you mentioned that. Okay, so the question was related to snacks. Kids are going to be eating lots of snacks. So if there's a breakfast option, a lunch option, and a dinner option, how do we account for snacks? It's going to be based on what meal that snack is closest to. So what a lot of families will do is they'll divide the day by time. Anything before 11 a.m. is using the breakfast option, 11 to 2 is using the lunch option, and 2 on is using the dinner option. So again, a great conversation to have with the family, and then we would just gauge, is that snack their usual, let's say it's after lunch, is it their usual lunch, less than or more than? Most likely the snacks are going to be a volume of carb less than their typical meal. So great question, thank you for that. Okay, so this is what I was getting ahead of myself on. This pump works with the continuous glucose monitor. So if a child, for whatever reason, does not have their sensor on, this pump will require a blood sugar entry every 4 hours, and it can only do that for 72 hours before it completely just stops being able to function. So very important that these children are wearing their sensors. There's no exercise mode. We're going to talk a little bit about the activity features on pumps and how we combat that later in this presentation. The only pump device that we did not have a representative for today is this newest pump coming out. It's called the Twist. It's Twist with 2 eyes, if you guys wanted to look it up. It's similar in size as the Mobi. It's just slightly different shape. It has a shorter tubing. We have not started seeing this clinically yet. We have not met with the rep ourselves, but it is on the horizon. So between now and the next time we see you at next year's conference, you may have some kiddos on this device. So if that does happen, reach out to us. If it's one of our kiddos, we will be able to talk to you about it at that time.
I'm gonna start talking about continuous glucose monitors. Before I say that, I just wanna share that I live with type 1 diabetes, and I've worn all of these technologies, so I'm really passionate about technologies. Sometimes we might get phone calls from school staff asking, you know, why a kid doesn't have one of these pieces of technology. And cost is sometimes a factor, but there's also the factor of we have a lot of kids that don't want to wear them. Whether it be they don't want kids to see the product on their arm or their abdomen, or whether it be they don't want the alarms going off during class. I feel like more recently we've had so many kids say, you know what, I don't want to wear these technologies anymore because of that. And we try to be supportive of, you know, their decision. We know that this would make life easier, but we also don't want them to get burnt out on diabetes, and so sometimes we just have to accept that they don't want these cool pieces of technology. So a continuous glucose monitor is a medical device that continuously monitors blood glucose levels, and these are just pictures of the ones that exist. The Medtronic Guardian, a lot of times, maybe you don't know that the Medtronic, it's a pump, which you saw today, but they do have a standalone sensor, but it does have to be on a phone. It doesn't come with a receiver like the Libre or the Dexcom. There's also now just the Libre 2 Plus, 3 Plus, Dexcom 6 and 7, but I have a feeling by the end of the year there's probably going to be another version of one of those, so they're constantly changing. Receiver. So receiver, I feel like, is a loose word because there's different devices that can be used to share data. So on the outer corners, like the Libre and the Dexcom, they've got their own, quote, receiver, and the receiver can only show you data. So it doesn't have any sharing capabilities, it's just there to show you data. A lot of times, a lot of our littler kids opt for this because I don't know many parents that are like, let's get my 5-year-old a cell phone, right? Which they do once they've been diagnosed with diabetes many times, but sometimes for whatever reason, cost, just don't want their kid to have a phone. The phones are also a receiver. All continuous glucose monitors can be seen on a phone, and then an insulin pump can also be the receiver. And something that I think it's important to also recognize is, let's say you've got a kiddo that does normally wear a pump and a continuous glucose monitor. If one isn't working, it doesn't mean the other one isn't working. These are still two separate devices. So little Jimmy comes in without a sensor, but they've got their pump on. You can still use the pump as a pump. Or little Jimmy comes in without the pump on, but he still is wearing his sensor. You can still use that sensor as a sensor. So work best together, but one can work without the other. Common difficulties, so accuracy. Especially now, there's a lot of issues with accuracy amongst continuous glucose monitors. Finger sticks will always be considered more accurate because they are measuring blood glucose, whereas sensors measure interstitial fluid. But what that means is you don't have to do a finger stick every single time they want to eat something or correction. Generally, we say trust the continuous glucose monitor unless, you know, they're not acting like their blood sugar's 120 and you're like, you are acting more like you're low or you're high. You know your kids. You know kind of their tells for that. In that case, of course, do a finger stick. Or, maybe you've got a family, a new diagnosis, and the parent is like, nope, I want you to do a finger stick every single time you're looking at that continuous glucose monitor. We would encourage the family to lighten up a little bit and not use a finger. Like, what's the point of having this awesome technology if you're still testing your blood sugar 10 to 12 times, right? And so you can bounce that back to us, say like, hey, maybe you should contact your endocrine team and ask if you really need us checking his blood sugar 12 times throughout the day. And we're happy to help with that. Signal lost, out of range, no data, that's another common problem. A lot of times it has to do with the proximity of the receiver to the sensor. There's some sensors that just have a wider range of where they can receive data from. There's some pumps or receivers that are better as far as like retrieving information goes. It doesn't mean that they're more accurate or anything like that. But generally, when you have that signal loss or out of range or no data, the sensor has not failed. The sensor is still working. It just needs to be reconnected to the receiver. So whether that be having the phone or the receiver closer, toggling on Bluetooth off and on, closing the app. That's another one. We deal with that a lot on our end because when kids close that app, like a hard close, it stops sharing data with us. So we know if they've closed their app, if they have parents call and want us to look at data, and we're like, nope, can't see it. So keeping that app open in the background helps just data being shared at all times. Sometimes it can take up to 30 minutes to see that data again. So having the abilities to do a finger stick if for some reason you can't see CGM data is always an option. Some other difficulties, keeping technologies on. I think in every visit with a kid or a parent, we're probably have talked about this or do talk about it all the time. These are just some ideas, not necessarily that you guys would have the resources for, but just, bringing to their attention. There's things that you can do under the CGM, such as IV prep, mastisol, skin tact. All of those just help the skin become more sticky. And then there's overlay patches, skin grip, sim patch. There's a bunch of those out there on the market. Some have fun designs, some are boring, but whatever they have to use to keep that CGM on is always a bonus. And there's a lot of, well, I shouldn't say a lot. Some of the pump companies, some of the continuous glucose monitor companies give them for free. So it's not always a financial burden. Unfortunately, not always the case, but you can tell the parent to reach out to us and we're happy to discuss that with them. KT tape is a popular amongst athletes. I personally really like KT tape because it bends. So sometimes just that little bit of bend helps when kids get bumped or something like that. And then bands, there's a picture there of like a band that's worn around the abdomen. There's a bunch of bands for all different types of CGMs, pumps, to just help keep devices attached. Alarm fatigue. So, kids typically don't want attention brought to them. Encourage families to reach out to us if their child doesn't want to wear their continuous glucose monitor because their CGM is going off in class all the time. I understand that maybe that child's blood sugar is 300 and it's going off because maybe they're sitting at 300 all the time. But I would argue that if we turn that alarm off and they still wear the sensor, that's still a win versus them deciding to just not wear the sensor at all. And so there's lots of manipulation we can do to those alarms. There's only one alarm that you can't turn off, and that's the urgent low, which is less than 54. So all other alarms can be toggled off. Of course, we wouldn't want you making that decision, so like have them call us and we'll help, tell them what's important for them. Sharing data. If a child is using a cell phone to see their continuous glucose monitor data, they potentially can share data with staff. And so I listed the 4 apps or the pieces that you need to have in order to share data. There's a lot of schools that like to look at all of their children living with diabetes data. And so Libre Link Up, Dexcom Follow, Bionic Circle, and then the Guardian Connect app. If the child is using a receiver or a pump, potentially neither of those devices are shareable. So it's kind of common, we get calls from family members, school staff saying like, hey, I have 3 kids, they all wear the Dexcom, 2 of them share data with me, but so-and-so doesn't. Can we get them to share? And oftentimes it's just because the device that they're using isn't a cell phone. And so because of that, if they're just using a receiver, unfortunately they can't share. And by share, I mean like you being able to see data maybe from your office and they're all the way across campus. I'm not talking about them holding their receiver and saying, haha, I'm not gonna share with you. Not that type of thing. Pump troubleshooting. So even with modern insulin pumps, errors can occur. Insulin infusion set blockage or occlusion, insulin site problems, bent cannulas, dislodging, leaking cannulas, extended malabsorption, you having your eyes on these kids all the time. If you've got a kid that's always got his pump site or CGM, did I go into yours? No, okay. on their arm, like encouraging them to rotate it different spots. Not so much with the CGMs, but pump sites can be worn any place that you take insulin. So you can put it on the arms, you can put it on the belly, you can put it on the lower back, and you could also put it on the thigh. App crashes is kind of a new one. Now that a lot of pumps are driven by an app, we've learned that if a kid has a lot of YouTube, music videos, things that are taking up storage, it can crash the app. And what does that mean? Well, if the app crashes, it essentially starts the pump all over again. So none of the settings are gonna be in there. It's not something that you can just restart at school. So that can be kind of frustrating at times. Empty cartridges, more so we're having schools inform us that so-and-so is coming to school all the time with empty cartridges, which means someone is not filling that insulin pump with insulin. Unfortunately, in those cases, it's usually the parents that have relinquished responsibility to the child, which is not always great. And then technology is not charged. So you have kids show up to school and their pump is dead. Unfortunately, they're not able to get insulin. We can see all of that data when they come in, like the report doesn't lie to us. We can see when their pump ran out of insulin. We can see when they're not charging it. So we go over that every time they come in, but again, we see them 3-4 times a year. You guys are with them every day. 5 days. What to do if technology fails? I know this is really tiny, but this is, yep. If technology fails, we've got the school orders here, and Juliet and Shannon did a great job, but when in doubt, we just go back to the standard injection with CGMs and finger sticks, and hopefully you have school orders either from us or from Banner so that you know what to do in those instances. And now I'm going to turn it back over to Jackie.
Right. Okay, so we've been talking primarily about pumps working in conjunction with sensors, and that's because what you're probably noticing is that's what you're seeing the most now. Based on how long you guys have been working with these kiddos, there was a time when we didn't have these hybrid closed loop systems, so the sensor and the pump did not communicate. So when we talk about advancement in technology, when we talk about the sensor communicating with the pump, what we're essentially saying is the pump is going to be releasing the background insulin. It's going to fluctuate that release based on the sensor data. So another reason why we really want the families trusting the sensor because we trust the sensors enough to allow it to tell the pump to increase or decrease the amount of insulin that that child is getting at any given time. So there's verbiage based on the pump company for what they call this kind of hybrid closed loop system technology. Medtronic calls it SmartGuard, Omnipod Smart Adjust, Tandem Control IQ, and iLet calls it Beta. These are all just words for automated insulin delivery. Okay, so we don't really utilize all those separate terms. Just the insulin is being delivered at a rate based on the sensor data. So the another component of this, and this is kind of like a safeguard mechanism that we really love about this technology, is the concept of insulin on board. So one thing that is always a concern if we're doing multiple daily injections is when was the last correction given? If we give another correction too soon, is that child going to have a low? So the pumps have this smart technology to recognize the amount of insulin that's been given, the amount of time that insulin is now circulating through the system. So when you give a correction, it can adjust that math to give less based on how recent insulin had been delivered. So we call it insulin on board, IOB, and for this reason, a lot of times when the kiddos you see are wearing pumps and their numbers are running high, you can see if they need a correction within that 2-hour period, because the pump will let you know whether or not it would be appropriate. All right, so another piece of troubleshooting would be preventing lows while kiddos are active. Exercise, traditionally is going to increase the risk of low blood sugars. So the first piece of this slide kind of goes over possible troubleshooting suggestions, not necessarily if an individual is wearing a pump that is within the automated hybrid closed loop system. And this is something that's really parent driven as well. Parents are more aware of how exercise influences their child's blood sugars. So it's definitely a conversation to have with the parent or guardian. But if you're noticing that there are trends of blood sugars running low during activity, these are some suggestions. And then with pump therapy, we've got some additional suggestions. So making sure that the starting blood sugar is around 120, that's going to help with preventing lows during the activity. And then maybe even providing a small snack leading into the activity. And then if the child is using a pump that is communicating with their sensor, we have some different modes that we can set them into to help. So they just have different names, but the Tandem, the Omnipod, and the Medtronic have a feature in which we can increase the target during activity. So these are modes that we would toggle on, maybe even 15 or 20 minutes before the activity begins. And now instead of their typical target of maybe 110 or 120, the pump is now set to keep them at a target of 150. So that is a way to minimize risk of having a low. The iLet pump does not have an exercise function. So with this pump, again, it would be a conversation with the family. One thing to note with the iLet pump, it says Beta. I apologize. iLet is made by Beta Bionics, so it looks like we've just interchanged some of those words a bit. So by Beta, we mean iLet. So if you were going to give a snack leading into activity with the iLet pump, you would have to disconnect the child from the pump. Because of the way the algorithm with this unique pump works, giving them a snack would adjust the algorithm, and it's just kind of makes for a complicated mess. So the per manufacturer instruction even is to disconnect from the eyelet if you were going to be providing a snack before the activity. And that's actually another option with all of the pumps. If a child is going to be playing basketball, you're going to talk to those parents, and most of them are going to say, we disconnect during play. Whether it's a device pump that has tubing, or even with the Omnipod, it would stay on the body, but we can suspend insulin during the activity. Again, I really can't stress enough that this is very parent driven. Those types of decisions are really more made by the parent than something that we would ask for you to make in the moment. And then of course the continuous glucose monitor. There's arrows. We love those arrows. Those arrows help guide us in terms of how concerned we should be about a child during activity. We always want to keep extra sugar options available for them, extra fluid available for them as well. Oh, back to Kelly.
Oh yeah, case study. So a 6-year-old wearing a pump and a continuous glucose monitor. So this is actually a real scenario that happened. The event happened at school, and then afterwards some of the school staff called and just kind of wanted to know like what was going on. So we received a call from the school stating that the child's blood sugar was 55 per the CGM during PE. The school staff said that they did confirm with a finger stick and the blood sugar was 58, which we would say is pretty spot on. School staff were looking at the CGM data. The child's blood glucose level was 200 prior to exercise, which the school did not catch. Therefore, there was no insulin given, but when they looked at the pump, they noticed that the pump read 2.34 units on board. So if you remember what Miss Jackie was talking about with the insulin on board, that means that the insulin has already went into the skin. It is in the body, and they were kind of like, well, how did that happen? Because I know that I didn't push buttons, the child doesn't know the password to the pump, so why the heck is there 2.4 units on board? The school had treated the low blood sugar, as always, provided with 4 ounces of juice, waited 15 minutes, which the blood sugar returned to 111. 30 minutes later, they noticed that the child's blood sugar was 183, with a trend arrow going straight up. So they called us wanting to know what they could potentially do in that situation, because they were just kind of confused of how the insulin got there and why the blood sugar responded with an arrow straight up afterwards. So what we explained was, with that insulin being on board, some of the pumps will go in and give automatic corrections. So because if you remember, the blood sugar prior to PE was 200, and so the pump said, well, wait a minute, insulin hasn't been given in X amount of hours, I'm gonna give a correction. I'm gonna take matters into my own hand. And then the blood sugar went low, and they provided the typical, usual treatment for low blood sugars, and then they had a rebound high. So something else that we're seeing with all of these pieces of technology is, because the pumps are essentially tracking that low blood sugar 30 minutes to an hour before it happens, it's already backing off on the background insulin, so the basal insulin. And so by the time that they hit that low blood sugar, there potentially is very little insulin left in the body. And so sometimes that 15 grams that might have worked when they were on shots, now all of a sudden is way too much glucose because they just don't need as much. Some kids are very sensitive to sugar, so 3 Skittles might really spike somebody up. And so we're not saying you should be the drivers of how to treat those, but it's possible that the parents might want you to give less when they're on a pump, because they do have those rebound highs from using the typical treatment of low blood sugar. And in that situation, I don't think the school did anything wrong. I think it was just understanding like why this happened, so that they know, okay, next time if this happens, this is what to expect, because there was nothing done wrong in that scenario. And I know it also depends on kind of when exercise or PE is compared to lunch or a snack, because had that child received some insulin, the pump wouldn't have auto-corrected it. So there's just so many factors for every single scenario. So unfortunately, this scenario you may never see, but you might see something similar. And if you don't understand what happened, please call us, and we're more than happy to kind of go through with you what probably happened based on what we all know about how these different pumps algorithms work, because they're all different and they all do different things. Yeah?
So what would you do if, say, they're 10 above their range, and we're supposed to do a correction, but you know they have PE next, and it's been over 2 hours since their correction? Would you wait till after PE is done, since they're not above the 200 range, or close to the 200 range, or would you do the correction and then have them go out to the PE?
So the question was, if we've got a child whose blood sugar is about 10 points higher than their desired range, but they're about ready to go out to PE, it's been 2 hours since the insulin was last administered. She was asking, do you give a correction or do you wait to kind of see what that physical activity did? I would honestly say 10 points above like a target is nothing to be concerned about. I don't think a correction would necessarily need to be given. However, I know there are those parents that don't want their child going over 200 and they're gonna tell you to give a correction. I think in that situation, it's just, you know, having that conversation with the parent and saying like, you know, historically, we see kids drop low, your child goes to recess, are you okay with us holding off on that bolus until an hour after recess, just to see? And I would say if the parent is adamant that you give it, and then the child starts having repeated lows, then calling us, making us aware of the situation, and then we can reach out to the parents and just kind of have a discussion about that. Yeah.
I would also add, you wanna keep in mind that just because you can give a correction every 2 hours doesn't mean you have to. And we want their day to have like minimal disruptions. So again, parent driven, and there are a lot of situations where, and this is gonna be really frustrating to hear, but it is the reality, diabetes is very gray. And there might be 3 or 4 different options in any given scenario, and none of them would necessarily be wrong. So it's just kind of something to sit with and recognize that that is the reality. Every situation is very different. You utilize the information that you have, the knowledge that you have, the resources that you have, and ultimately, whatever decision is made is probably gonna be fine.
We'll hear them here.
We have parents who have been telling one of our health assistants to do something called a ghost card. Is that a thing?
Clutching my pearls.
It's like this is a fun new term, and like I understand the concept of why, but I don't, because I feel like that's gonna mess with the algorithm of the.
So she's asking about ghost carbs. If you've never, ghost bolusing, what that means is you are telling a little fib and telling the pump that you are eating 5, 10, 15 grams of carbs, but you're not actually eating those carbs. We stress to parents not to ghost bolus because it tricks with the algorithm. It's hard for us to see where setting adjustments are needed. And if the parent is adamant that you do it because maybe the sugars aren't where they want them to be, I would encourage them to reach out to us and say, hey, some adjustments need to be made to their regimen so that we can not put you in that situation. We are getting real close to time. I'm gonna have us move into the next presentation, but after that, we have Dr. Tawari speaking, and after her, we have a whole time cut out for questions. So save your awesome questions for the very end, and we will get to them. It's me again. I'm doing this presentation as well. Danielle and I are both diabetes educators at the clinic, and we both live with type 1 diabetes, and so we just wanted to put this to a few slides. It's not super long, but talking about that kind of emotional piece and how to verbiage to be using. There is a handout in your packet that is, oh, I thought I grabbed it. It's from the ADCES. It just talks about using certain language when speaking to individuals with diabetes. And so, as you know, the individuals that you are working with are pre or post puberty, and so they are lots of changing emotions just in general, being a child. And then you throw diabetes on it. And I can speak from personal, oh, here we go. Thank you, Danielle. This is what it looks like. Speaking from personal experience, Danielle, you were diagnosed at a young age as well, right? Age 9. So 9 and 10, like we both went through school with diabetes, and it wasn't a positive experience for myself, just because there is that feeling of denial, guilt, anger, frustration, on top of just dealing with normal emotions as a teenager.
So we want to think about the language we're using, that it's neutral, that they don't feel judged, that they don't feel that they're different. Even though they are a little bit, they're not that different from every other kid. But it's free from stigma. Even I remember as a kid where I'd say, oh, I have type 1 diabetes, and someone would go, and I would just be like, don't do that to me, I'm not broken. I'm just a little special. So we want our language to be strength-based, respectful, inclusive, and imparts hope. And above all, is person-centered.
So now Danielle and I are going to do a little acting scenario for you, just for funsies. So in this scenario, I'm going to be the school representative, and she is going to be the individual living with diabetes. And so if I was the school representative, and I would say, you are a diabetic, you need to come see me before your lunch hour every day so I can give you insulin. Danielle, how does that feel?
I think you meant person with diabetes.
Oh, my bad. I did mean person with diabetes. So I don't know, maybe for me, I hate being called diabetic. Like I don't like being referred to a diabetic. I'm a person living with diabetes. You are caring for children living with diabetes. You're not caring for diabetics. I hate that technology or that terminology. It gets under my skin, and so we don't want to label someone as a disease. They are living with it, so try not to address them as a diabetic.
We're going to do another one. Kelly, your blood sugars are way out of control. What is going on? What are you even doing?
It's those Takis.
You know you can't have Takis, that's not part of the healthy plate method.
But Sarah's eating Takis and she wanted to share them with me.
So in that situation, it wants to be like, okay, well, how many carbs are in a bag of Takis? And when you're above range, let's say her blood sugar is high, I like to use above range and below range because it doesn't call into a judgment. It's just saying, so what is your doctor or your diabetes educator asking you to do when your blood sugar is above range? Are you supposed to do anything special with your pump? Or are you supposed to come to the school nurse? Are you supposed to come see me? You know, being supportive. So sometimes, even when your language, well, I want to say body language is also important, which we'll get into, but even if you're calling someone diabetic and that's a trigger word for them, so they might just already start shutting down and stop listening to you, and then they're not going to benefit from everything that you're learning today.
And I like the way that Danielle phrased, like asking them what they would do, like just being a teenager in general, telling them what they need to do probably isn't gonna pan well, but asking them, you know, what do you think we should do? Dr. Patel, Dr. Tiwari, they're all, even in the appointment, they'll ask them like, what changes do you think we should make? And I'm shocked sometimes at the amazing answers that come out of these children's mouths. It's like exactly what we were gonna do, and they understand, you know, what needs to happen and why we're making those changes. So getting them involved can also be really helpful and impactful, so that you have more of a two-way communication between you and the student versus a very closed down student. We know that you're just there to help them, but unfortunately sometimes their brains can't accept that and they think that you are the bad guy, but we know you're not. But it's hard for them to see that.
And even body language, sometimes we know that the tweens read into things. They always think they're yelling at them. I've raised children. I know that when I'm like, you know, I asked you to do that 2 hours ago. Why are you yelling at me? No. So I had a child who was diluting her urine because she knew she had ketones. And when we addressed it in the visit, I said, so I don't understand. If you have ketones, you just need insulin. And basically she said, well, whenever I have ketones, the school nurse is mad at me. And we kind of was like, I don't think whoever it was, I don't think they were mad at her. We said, well, could she just be worried and concerned and knowing that she has to do something so you don't get super duper sick? You think that might have attributed to the way she was communicating? Oh, okay, maybe. So we just, as we all know, have to be a little bit careful when approaching somebody with an unstable blood sugar. And also, that's why that t-shirt was invented that says, I'm sorry about what I said or did when my blood sugar was out of range. All right, so.
That's it. It was just kind of a short presentation about language and it matters. And again, we know that you guys are there to support them. We are not finger pointing. It's just a good reminder, because I myself say, you're a diabetic. But I hate when people say that to me, so I have to remind myself, like, no, they are living with diabetes. So next we're going to turn it over to Dr. Tiwari, and she's going to do a presentation.
You have to have me pull it up.
I can help you.
Did you put it on the?
Yes.
Put it on the.
Cool. Got it. Nope. Got it.
And then let me. Okay, hi everyone. This is a lighter topic, believe it. This is not all about insulin and doses and all that. It's just a little reminder about other things that can happen with type 1 and how you will see kids who will have other needs besides their insulin. So the first one, we see a lot of kids who have type 1 and also have autoimmune thyroid disease. It's the same mechanism. The immune system has gotten confused and is making antibodies that are attacking thyroid tissue, and over time, they end up needing replacement thyroid hormones, levothyroxine, Synthroid. Usually this is given at home, so it may not be such an issue at school. If they are not well controlled, they are very tired and sleepy, and you may see that. But this is just a reminder, almost a quarter of girls with type 1 will have thyroid disease. So that's why we check these children, we check their thyroid levels every year. They can have underactive gland, which is the most common, but they can also have an overactive gland or Graves' disease. That causes the opposite effect. They're very hyper, suddenly their personality changes and they're acting like they're on caffeine. That may be something you may see, or a lump in the neck, and you can probably tell them, hey, maybe you should ask your doctor to check your thyroid. That's one. Second one is celiac disease. I bet you have kids in your school with this. Even kids without type 1 have celiac disease, and some of us wonder if we should be checking them for type 1. And I have started doing that. If they come to me for celiac, I have started checking their A1C, I have started checking their thyroid, because these autoimmune conditions often cluster. So celiac disease is the same thing, but this is the allergy to a protein called gluten found in wheat, barley, rye products. So the ADA recommends checking it if there are symptoms of abdominal pain or bloating after you eat foods containing wheat like pasta, bread. But we check it every year because we never see symptoms. This last month, we had 2 kids with newly diagnosed type 1. One's titer for celiac was through the roof, the other was medium. So both we think have celiac disease. And on occasion, I've had patients with type 1 celiac disease and hyperthyroidism or hypo, all diagnosed at the same time with no symptoms of hypo. So I have started checking, we all check them every year. So most people know, gluten-free products are available, they don't contain any of these components, but oral care products are often overlooked. Some toothpaste and some things or rinses have gluten in them. They're not gluten-free. Soy sauce is another one. You have, and Callie taught me this, you have to get a special soy sauce called tamari, which is gluten-free. Play-Doh or slime, some of them have gluten, and some other condiments. So that, just a reminder that, okay, if you have kids that have celiac disease, maybe check with lunch people that they're giving them the right food and things like that. Some kids will cross-react with oats, so the gastroenterologist will tell them to avoid oats as well. So it can be tricky in school cafeteria when it comes to oats. Next one is adrenal insufficiency. How many of you have kids who need stress dosing with hydrocortisone at school? Does anybody? Oh, quite a few, okay. So this is another one, and this is a bit more rare. So it's the same mechanism, immune system acting funny, making antibodies against the adrenal glands, which are situated above the kidneys. Their job is to make cortisol and other steroid hormones called androgens. We need cortisol all day, every day, and we need extra when in the morning time and evening time. That's why if you guys have noticed, if you've been working all day, didn't sleep, come to work the following day, you still have energy in the morning and in evening. You crash in the afternoon because it's the cortisol levels. You need this cortisol. So the immune system is making antibodies that are attacking the adrenal, and now these children have adrenal insufficiency. So what do they present with? They're tired. If they already have type 1, you think, oh, they're tired because their sugars are high or maybe low. But what you will notice, they're not growing well, they're not eating well, they're losing weight, and somehow they now need less insulin. They were either not well controlled before or well controlled, but now suddenly they need less insulin and they're older, which is weird. When kids are growing up, they're going through puberty, they need more insulin, not less, unless they're super active. So that's a clue that triggers us to check the adrenal gland. Okay, so we check their cortisol levels. Now the treatment for cortisol deficiency or adrenal insufficiency is to give cortisol or hydrocortisone, which is usually oral tablets given either twice a day, 3 times a day, depending on whoever prescribed it. However, if they are sick, then they need extra. So you will see them, most of them will be on hydrocortisone. There are some that need fludrocortisone, which is another kind of steroid that helps with the sodium and potassium balance. So some of them may need a dose in school. We try not to do that, but the little ones sometimes need a dose in school. When they're sick or stressed, and we're not talking emotional stress, we're talking an illness like a fever, a fracture at school, stomach bug, or, that's when they need 3 times the dose, triple dosing. And often we will send a letter stating that. Occasionally they need an injection. Suppose they're vomiting, you cannot give them their medicine, they're puking it out. It's been, in less than 30 minutes, it's already out of the system. You have to give a shot. So some of you send me forms that I have to sign for the injectable steroid. So that's something I wanted to bring up because we did have a patient who required it at school because they fractured their arm. This is a drug that EMS will not carry and will not give. So I do tell them to have a bracelet that says steroid dependent, but many times they won't have that. So it's very important for you to know who is this kid who has adrenal insufficiency, because in emergency, it's a big deal. So that's really all, and I did want to recognize our student, Sebastian. He is part of our team for this month, and his assignment was to start working on this presentation and create slides, which I think he did a good job. So he deserves a little bit of credit. That's about it. Any questions, or should we ask questions later?
Nope, so this time is where any question that you have about anything that came up today, we've got a panel of experts, us educators, the doctor. I would also encourage you to get those post surveys out and have both the pre and post surveys ready, because we are gonna collect those from you all. We really appreciate you filling this
Everybody
out.
just passed them this way, is that
And then
sufficient?
after the
Or do we
question and
you want each
answer, we're
person's?
gonna have a
Okay.
raffle,
That's okay.
and we've got
Mine's
12
the one with
gift
the scratched out
cards to
name.
give out, and there's about 60 of you, so those odds are pretty good. Like 1 in 5, right? Yeah, okay. Yeah. I know you had your, yeah.
Yeah, if a child skips breakfast when they normally, that's part of their routine, to have breakfast and get their insulin. If they were to skip their breakfast completely, would that cause their blood sugar to skyrocket?
So the question was, if the kiddo is to skip breakfast completely, she's asking if the blood sugar will rise because they don't get insulin.
Yeah, is it the body trying to figure out, hey, I didn't, usually I get insulin?
So why that happens?
Yes.
Yeah, okay.
You want me to sit?
Okay.
So assuming the kid is on a pump or not on a pump, if they skip breakfast and sugar has a distinct jump, it's either they ate or drank something and didn't tell you. Chewing gum is one, sugar containing chewing gum. Sometimes if they're stressed, maybe it's a test and they're super stressed and cortisol was made, a lot of it, that can sometimes do it. Usually it's not a very high jump. The first thing I would say, it's likely he or she ate something and didn't mention it. What else? I'm trying to think. CGM not correct. So if they don't eat, the jump would be usually at 3 to 4 a.m. from cortisol being made. Again, physiologic cortisol being secreted at 3 a.m. or 3 p.m. But breakfast, I don't know, some sort of emotional stress or something happened, illness,
Oh, that's right, or you probably more
Fever.
likely ate something and didn't wanna say.
that would be the most common reason. Maybe the kid thought that it was a small enough thing that wouldn't rise the blood sugar and it did.
Or I just thought of something, maybe at home they ate bacon and eggs, which parent didn't dose for because it doesn't have any carbs, but high fat, protein, it still gets broken down into glucose, and so you can see that spike hours later.
It's not a very high spike, it's high for a longer period.
Okay.
And I wanted to include, if the bacon is maple cured, it
Oh,
may
yeah.
have hidden carbs.
Yeah. Yep.
I'm telling you, yeah.
For the adrenal insufficiency, I actually have a student with that. We're trying to prevent diabetes. She started research on chronicity. Have you seen any positive
Yes.
results with that?
Yes, so there is a condition called congenital adrenal hyperplasia. Oh, sorry, I have to repeat the question. So the question was, one of our nurses or staff student representatives has a patient who is on a medication called chronicity, and she or he has adrenal insufficiency. So there is a condition called congenital adrenal hyperplasia in which the adrenals have an enzyme problem and they just cannot make enough cortisol. These kids require a lot more cortisol, they require fludrocortisone to manage their salt, and they make so much androgens that their bones are maturing faster. So it may be a 6-year-old with the growth plates looking like a 12-year-old. And we know that down the road, they're gonna have early puberty, they're gonna be extremely short. So chronicity is a brand new medication that came out that works on the hypothalamic level. So if your adrenals are not making steroid, the pituitary gland, the brain is giving a higher signal, so ACTH levels are higher. The brain is also giving a higher signal to the pituitary saying, come on, tell the adrenals to make steroid. So chronicity works at the hypothalamic level. So it's a brand new drug and I'm excited. I've had some patients with good results. So you may see that, but it's not like you still have to stress dose the same way when they're sick. Yeah, good question.
Okay, I have a question, I don't know, I've done school nursing, I'm a school nurse, this is my 3rd year, only second full year, so coming in at the beginning of the year, getting the paperwork and the document for the diabetic students. Really, truly, my first time feeling like I have somebody that we can call. So you guys keep saying, call us, we'll call the parents, call us if you have questions, which sounds great, because we have some difficult parents, and all of that kind of stuff, and a lot of disconnect. So, how do we need release of information? Do we need permission to speak to you about a student? How does that, what do I do?
Well, I don't know.
So the question is, in helping the parents understand?
Well, no, but also just to communicate information about the students. So if we have parents that just aren't really helpful in the situations and we're seeing, a disconnect in care, communicating with the parent, but also bringing you guys on board to also reiterate the importance or maybe make a connection that I just can't make with these parents.
I would say that most of us want to hear from you if you're concerned about anything. We want to know, we want to be part of the conversation with you, so that when they come in, we can address it in person with them and say, oh, hey, we've been talking with the nurse and she has concerns about this one topic. What are your feelings and what's your experience, and kind of helping them work it out. And helping them also understand that you guys have your limitations, your capabilities and your limitations, and that's a huge part of keeping them safe at school.
Well, what about the HEPA law?
So to get permission.
So on the school orders that we release out, it says right on there, it gives you the permission to contact us. So if the child does belong to us, TMC, and we provided you with school orders, that says that it's okay for you to contact us about your questions, concerns, that type of
But do you
thing.
provide those school orders automatically?
What was that?
Do you send those school orders directly, or do I have to call you and tell you? Are you guys telling us?
So every visit, we are offering school orders
To parents.
to parents.
Yeah, and then they have to bring it to me, which they never do.
Yeah.
So that's how I'm saying, how do I get the
So
school
we've
order?
had, school staff reach
Oh,
out
that's
to
him.
us and say, can we get so-and-so's school orders?
Okay,
And then we can send it to you.
and I don't need permission, I just tell you who I am, what school, and you'll fax it to the school.
As long as we have made note of, in the visit, where the school, the student goes to school, and we have that same information, we can send it to you. But if this is a new school and we have no clue that they're going to your school now, we usually call the parent and say, hey, we received a request from the school, is it okay for us to fax it over?
Great, okay, thank you.
Most of the parents, there's a couple things I wanna say here, most of the parents do understand that it is essentially a requirement for them to be in school to have updated school orders. So that's definitely not new for the parents. And also I wanna stress that we really appreciate you guys contacting us. I say it every time I speak with one of you on the phone. You guys are our eyes and ears 5 days a week when we see these kiddos once every 3 months when we're lucky. And there have been many occasions in which we've received a phone call that was concerning and we were able to contact the family and get them in sooner. So we do appreciate those calls and we always wanna work as a team because we all have the same goal. So it's never a problem if you have a concern to reach out to us. On that note, you are also mandated reporters. So if you have concerns that go a little bit above and beyond the level of what we can do, we really stress that you contact DCS. Okay, most likely, if you're contacting DCS, we're contacting DCS. And the more calls they get, the more likely it is that that child's gonna be helped, so. keep that in mind.
So at TUSD, our med permits that the parents sign, they give us permission to ask questions. So that could be one way for us to be covered. My other question is, what do you prefer? If we're noticing trends, do you want us to email you, scan, or fax you records? Do you want to call? Like, what is the best way to communicate questions about just general trends?
I would say that the easiest way would be to start with a phone call. And then from there, we can see what additional information you guys have. We might not need any information. If the child is sharing their pump data with us, we may have all that, but it's kind of the conversation related to the day-to-day. Is the concern that the child's coming in with a pump that has 2% power, that has 3 units of insulin? Is the issue that they're hiding during lunch and no one can find them? So it's really more what the specific concern is, and that's always the best place to start.
And if I could add, a lot of times we then play phone tag with you guys. When you call, if you have to leave a message, if one of us isn't able to speak with you right then and there, if you could say like the best time to reach me is XYZ, just so we will likely get a hold of you the first time, that would be awesome. And because we want to talk to you, but sometimes it's really hard just because you all have busy work schedules, we have busy work schedules, and so knowing that like, okay, so-and-so is gonna be available at this time just helps us reach your needs faster, more efficiently.
And don't forget to share your fax number with us.
This, I think, encompasses a lot of the issues that we have with kiddos that are on closed loop systems, just like all of the things that can go into that and like management on a day-to-day basis. But we tend to have parents and even some of our staff that you know the kiddo, you sort of know what is gonna happen for them. And so you try to prevent it by changing what the pump is saying. And so I've started when we do our education and training for our health assistants and staff that we work with, and conversations with parents talk about how important it is to try to sort of stay with that and then make adjustments. I just wanna make sure that that's the right message. Like, is that what, because a lot of times, for example, let's say a kiddo has their carbs and correction factor for lunch and it says to give them 3.5 units. We ask the parent and we say, you know what, I'd rather do 2 because they're gonna go play. That feels like if we're doing that consistently, we're sort of messing with okay, I just wanna make sure that that is like a message that is
definitely is, because if you're essentially overriding the pump every day at lunch to give less or give more, well then, if we see that, we're gonna go, I think we need to adjust the carb ratio and the correction for this time of day. If they're concerned that they're gonna go low or go high, or they're adjusting, they're putting in ghost carbs or all those things, like that's usually an indicator to us that something needs to change here.
And you guys can see those things happen, but I think.
We can, and you feel free to call and let us know. Let us know if you want us to call you back, or hey, I just wanted to let you know, to look into this.
Yeah, but we cannot see ghost carbs.
They don't know that those are not real carbs.
And some of the pumps, there's an override that we can see, but we have to be looking for them, and they have to be in certain views for us to really see it, so, thank you. Yeah.
So I have another question, so with regards to all this, so, sometimes like for a correction and the pump decides to give like a certain amount of insulin, and when I talked to the mom, like she was saying, she oftentimes say, oh no, give this or that, so that then would, just to clarify, would be a reason, if that happens more often, to call you, so that is to kind of check on that.
I think it comes from a good place, right? They're concerned about safety and they know their child, they know what's gonna happen, but for me, it over the years that we've sort of been learning about pumps and working with them, it's been like, they're so smart that I think we're almost messing with.
Right,
their
you're right.
ability.
So when we have some parents that have a lot of anxiety about this, and so they want to think over the pump, and we want to discourage that. It's the kind of thing where it won't happen in one visit, but if every visit we keep encouraging, trust the pump, eventually they stop doing that. So if you also talk to them, we talk to them, I think it will help them.
I talk a lot with parents that are super anxious about, we have what we need, right? Even if your child goes slow, we know what to do, right? We've talked about that, we have a plan, we've talked with the teachers, and so like alleviating that concern that maybe they will, right? But maybe they won't, right? Maybe it's right, and we're doing something that might not even happen, and like giving it a minute and take a breath.
Right. It's either insulin or more food.
Right.
It will be fine.
Any other questions?
Oh, calibration.
Oh, yeah, oh shoot, that was on my slide and then I didn't talk about it. So calibration, some of the continuous glucose monitors have the option to calibrate, some do not. And so if your continuous glucose monitor can be calibrated, you can calibrate it. However, a lot of what Dexcom says, because Dexcom is the one that can be calibrated, you're not supposed to calibrate more than once every 24 hours. So having a conversation with the parent, if they're never calibrating, then absolutely, you can calibrate it slowly. But if they're calibrating every morning, then you calibrating can mess with the accuracy of the sensor. Some other issues with accuracy of sensors that I didn't really dive into, dehydration. Kids that are playing at recess, PE, they're probably going to be more dehydrated, which is only going to lead to more inaccuracy of sensors. And just as a general rule, the best time to calibrate is when that trend arrow is flat. So trying to calibrate when you've got 2 arrows up or 2 arrows down is kind of a pointless calibration because the trend is happening so fast that there's no point to calibrate. And even though the Libre cannot be calibrated, if blood sugars are going up or going down too quickly, it will ask you to calibrate, or ask you to do a finger stick, excuse me. You can't actually put what the blood sugar is into the Libre, but it will say, hey, blood sugars are rising or falling too quickly, I'm not accurate. That's what that's telling you when it's asking you to do a finger stick. So in that instance, I would say do a finger stick because the CGM is telling you it's not accurate.
Just like curiosity wise, it always tends to be when they've gone low or been high, that is way off, right? Like what is happening? Physiological. I think I might know, but I'm curious.
No, so these sensors are less accurate at very high numbers and very low numbers, which is why we always say check the sugar by finger stick, which is the most accurate method. Arterial blood glucose will be even more accurate, which we cannot do, so we do venous blood or capillary blood. So that we do see, and having said that, lately, we did have some reports of one of the Dexcom sensors, the G7, acting very different, being way off, and I think there was a recall on the readers recently, so this is technology, sometimes this happens. If you notice it during the day a lot, you can probably ask the parent to change the sensor, and they might probably put a new one.
What about parents that don't want any fingers stick? Sorry, I'm sorry.
There are parents that don't want any finger stick.
You know, it's
I
awesome.
would not want a finger stick if I had diabetes, right?
I think just reminding them that a finger stick is the most accurate, and if they're being argumentative, you can always pin it back to us, say, call your doctor, cause we'll explain to them like, yes, we want you using these amazing pieces of technology, but unfortunately, they're never gonna replace an actual finger stick. So, yeah.
Can you speak, and I've seen your newest order set on a couple of our kiddos, but I can't remember the exact verbiage. But it says, I remember it says in there, it's just highly discouraged to override the pump. When you're looking at ketones with the moderate and large adjustment for that dosing, are we overriding the pump? Are we using pen? Will you just talk about that a little bit?
I mean, anytime there's ketones present, we would encourage you to use a pen, because we can guarantee that that insulin is going into the body. If the reason ketones are present is because the site is faulty, whether it got bumped at recess, whether mom put a new site in the morning and it bent on the way in, like, we don't really know why those ketones are present, but what we can guarantee is that they get the insulin if we give it through a manual injection. So we encourage parents at our visit to give the school insulin pens for that exact scenario, that for some reason you can't give it through a pump. Now let's say you don't have a pen, I mean, try to give it through the pump, you know they need extra insulin, but in that case, manual.
We did update our orders to say give an injection, to avoid that confusion.
But
Yeah.
then if they're still wearing their pump, are we taking the pump off and converting to manual injections for the rest of their school day?
I don't usually tell them to take the pump off. I just say manually give the injection every 2 hours, check the sugars. Let the pump do its thing, mom can take it out at home.
And the pump it'll be safe still that we're giving them additional insulin by pen, with the pump not being able to see necessarily those units that we're giving.
It will be able to see if the kid has a CGM, but if there's no CGM, then you can take the pump off.
Okay, so if it's a closed loop system, we
Right.
can leave the pump on, but if
Yes.
it's not, then we would need to remove the pump.
Right, and if you're not comfortable, you can take it off. It's not gonna do anything major. If it's a closed loop system and there are ketones, then likely the pump or site, one of them is defective. And so, it doesn't change anything if the CGM is working, but if you're not comfortable, you can take it off. I don't know, do we have any orders in that about this, about taking the pump off, or?
It doesn't
No,
specify.
it doesn't specify, and that's because we have patients, that are very, and you probably have heard from those parents that don't want you to remove the pod and they want you to do corrections, and it's kind of all over the place with experience. So, just like Dr. Tawari said, and I mentioned earlier, is that if they're wearing a CGM, it will detect that their blood sugar is trending lower, and it's not going to attack it like you might think it is, even though you have just done a correction. So I think we might need to clarify that, and you all let us know if it's not clear, but that's the reason, is that so many patients are all over the place with that.
Some high school kids can change their site. They have an extra one and they can just change it there, and, so everyone is different when it comes to this. Now, I will say that if you have kids that have ketones and the sugar says normal on the CGM, double check with the finger stick, cause these things can be off even at normal levels. And you'll see a high and you go, oh, that's why you have ketones. The CGM is not reading it.
I've also had that situation happen too, but I've been able to stop the insulin, just pause the pump itself. And then also you could enter inside the Omnipod, well, I work with Omnipod, you could enter how much insulin you gave. And it I guess it just keeps it as a record into the system.
Okay, yeah, so one of our attendees, they know how to work the Omnipod and they know how to suspend or pause it, that's an option. And with this particular Omnipod pump, you can enter it, but if you didn't, that's okay too. Yeah, whatever works for you, removing it, pausing it, suspending it.
For how long?
Yeah, this is not an expectation for you guys to learn or know how to do. I think we're diving a little too deep into specifics that as a health aide, as a nurse at school, we don't want you to be playing that mental gymnastics with the pump functions. That's why it's much more of a blanket statement, the way to manage this. The goal while kids are in school is to stay safe. So we're focusing on getting those ketones flushed out, we're focusing on managing the blood sugars, and you don't have to worry about, well, can I suspend this pump over this pump? That's not necessary.
And your question was how long? You would give insulin every 2 hours until ketones are trace or small. Or
If we're disconnecting the pump, like you said, I understand that you just mentioned that, but we are administering insulin by injection. So we have to pause to remove the pump. For how long we wait until we admit, like,
You
tell the
wouldn't
student
be
to
doing
jump.
that if the child is wearing a sensor. So again, we're kind of getting into the deep dirt right now with like
Yeah, 'cause
really,
we're not gonna
really
restart the
too
pump at
specific
school.
recommendations.
At school, we're gonna stick with shots, so that would be mother's job or parents' job. And this is the kind of thing you can decide at that 504 plan, when you see them, like, this is how we're gonna do when this is what we're going to do, and that really helps.
When the child has ketones, most likely you're going to be reaching out to the family, and at that point, they may say, I'm gonna come get them, or just give them a shot every 2 hours until I come get them. So again, each individual situation is unique. We can't give an answer for each unique situation. Like I said earlier, there's probably 4+ options, and none of them would necessarily be wrong. Again, keeping in mind, what is the goal? The goal is to keep this child safe. So are the blood sugars high? We need insulin. Are they low? We need sugar. We wanna simplify that.
Do you recommend that, anybody that's like type 1 diabetic have a 504? You keep
Oh,
it.
yes, I think that is very helpful, a 504 plan that is clear, okay, if I have a low, can I treat it in class, or do I have to go to the nurse? Where is the phone kept? Am I allowed to keep the phone? Every school has different rules. So I think that's a very good way to all sit down together and know the expectations, and it lets the parents know that you care. So I think it makes things very easy, because I've had high school kids tell me, my teacher doesn't like it when my pump beeps. Well, the CGM is beeping for a reason, the pump is beeping for a reason, so then if you have a 504, then that educates the teachers as well, that hey, you cannot do that. This is a medical device, the phone is now a medical device.
Why can't they make those
And
just
how to deal
vibrate?
with other kids
Are
that
they
say, if
alerting it
she's
for the
allowed, I
patient, or
should
are
be
they
allowed.
alerting it for everybody around them?
The patient.
So why can't they just do like a haptic?
I assume if they don't feel it, they're gonna miss
My
it. But I'm
general
not exactly
feeling
sure.
is that there's an issue
I solved the
with
problem.
CG and the pump, whatever. I'm going old school. I have instructions to give insulin, to give juice, and check every 2 hours, and I'm gonna monitor my kids.
That's really all you need to do.
That's-
Perfect, yeah.
And that's what I'm gonna tell my health
Yeah.
aides to do, because you
Yeah.
know what? I know that works, cause I've been doing that for 30 years.
Yeah, that's why we have those, but technology is only going to get increase. I mean, there's another pump on the market coming out. It's just, all these closed loop systems are gonna get better. You never know. I mean, there might be another CGM in the next year when we talk again, so it's changing.
So a lot of our like safety issues come from the kids not having backup supplies. So, first thing is asking the family and, sometimes there are difficult situations. So what kind of resources do so the next thing I do is say, okay, well, let's call the clinic. Sometimes that works and sometimes it doesn't, but like what kind of resources or, how can we work together to kind of make that happen? I've heard that you have a social worker.
We do have a social worker, but in the past, we used to get a lot of samples of insulin, of lancets, testing supplies. Now, the meter we get doesn't even have any lancets in them. So we don't have as much resources in terms of backup supplies. But we tell them, go to Walmart, get the cheapest meter there, and get the test strips. But this is a good point to talk about it, the 504 plan. Like, if you don't have supplies, our policy is to send the kid back home. And then somehow their supplies will be there. You have to have a policy. Yeah.
And I can't speak to the other endocrine clinic, but like at our clinic, we are writing for 200 test strips for every single patient, whether they use a CGM or not. So they have the supplies. Whether they bring them to you, that's another point, but somebody came up and asked me about a meter. That one might be a little bit tricky because the insurance companies kind of dictate how many glucose meters they'll cover a year, but a lot of the companies, if you call them or go onto their website, they will send a meter for free. So if cost is an issue, there are some items that are free. Not all items, but some items are free, and so calling us and asking us about that, we can at least kind of help kind of drive you in the right direction.
What about alcohol swap wipes? I've heard two things, that they're included in the prescription, then I've heard that they can't afford it, so I run low.
At our clinic, we include it.
Okay.
We include it, but Access specifically has stopped covering them because you can buy a box at Walmart, 400 for 98 cents. I've looked on that price. I know that sometimes 98 cents is just not doable for a family, and so soap and water to clean the skin.
That sounds more like an excuse to me.
Yeah.
I know, I'm just saying. I know everybody's financials.
Since we're talking about supplies and responsibility of families to bring in supplies, that is one place, when a 504 can help. Everyone's together and it can be made clear to families that no, but the schools do not supply these. We don't buy glucometers, we don't buy insulin, we don't buy EpiPens. What your kid needs, you bring to us, and a 504 makes that crystal clear.
Yeah, so at time of registration, they have to fill the nursing form and give it to the nurse, and that's. They don't do that?
Your expectations are so high.
They're supposed to.
Oh, wow, my kids school hounds us, like, you have to do it, it's USC.
We have that.
Yeah.
You just don't do it. Yeah.
Oh, wow. Then they don't get to start school.
They can't deny it.
Then they will do it very quickly, because they want these kids in school.
It's very frustrating to some parents
Sorry.
to get the information we need, and, like I said, we don't even know how many diabetic children we have.
Oh, cells, okay.
Yeah, we don't know.
I do have some kids that we find out years later that they never told anybody they have diabetes. Mostly type 2s do that, because they don't want to be treated differently. And that's why they never control their sugars when they're at school. And it's very difficult. Some kids tell me that their schools do not require them to go to the school nurse. It is recommended, but they do not have to do it, so.
But if we don't know they're diabetic, then we
Yeah.
can't work with them.
Right.
And
Right.
I'm a little scary maybe, but.
Me too. But I think these kids are the ones that need the help the most. Because in their family, having diabetes is no big deal.
Exactly, it's almost an expectation.
Yes,
You know, everyone gets diabetes.
Yeah.
Everyone loses a leg. Everyone ends up on dialysis.
and it's genetic,
And then they die.
yeah. It's very sad. But if you bring it to our attention, that, okay, with this kid, this is what you should work on, then I will.
So, you had a question?
Yeah, I just was wondering, I heard recently there's an increase in A1Cs with ADHD medication. Are we like are you diagnosing more with that, or what are we looking at with that?
So they have, sometimes they have insulin resistance and the A1C goes up slightly, but it's not, it doesn't go to the extent of becoming diabetic. It's a
Okay.
pre-diabetic, 5.6, 5.7, 5.8, back to 5.6. So we work with them with their choices of food and sweet drinks and stuff.
Okay.
It's not very common.
I'm just curious with the new eyelet pump, are you seeing mostly success? Is there ever a time when you're just not successful for someone and you come off of that and have to go back to something else?
So we don't have a huge number of kids on this pump yet. The ones that we do have, at least I have maybe 3, maybe the other dogs have more. We have seen mostly that they work well. We have to help change their habits because this pump is different from the other pump. The way you treat a low is different. So we have to work with them and learn as we go. Yeah, but so far I haven't seen anything super negative with the pump. Yeah. Bit more lows, I guess. Yeah.
How long is the learning process on it? You know, from the time that you put it on to where it actually starts to know the child?
A week. I have to look it up, what they say on the menu. A week. Oh, the rep said a week? Excellent. The rep's going.
Starts to really pick up trends and actually.
That takes them to all weekdays and all weekends.
And you might be thinking, why isn't everybody on the island? Because you don't have to count carbs, but every pump is individualized, so it's not right for everyone. So like a kiddo that can't keep a CGM on, the islet is, not the pump for them. And so, we
Family that wants a more hands-on approach.
Yeah.
That likes to micromanage a bit, would never want the island.
Teenagers say it's too bulky. Some don't want a tubing. Some want to use their phone for everything.
And insurance dictates, correct?
A lot of it is insurance as well, yeah.
No more questions?
Thank you.